This conference will now be recorded.
Hello, everybody, and welcome to the AnCan High Risk Recurrent and Advanced Prostate Cancer Video Chat session for Monday, December 18, 2023. I'm Len Sierra, and I'll be moderating today with a little help from my friends. We want to thank and acknowledge our sponsors, Bayer, Myovant, Janssen, Myriad, Telix, and Foundation Medicine. And
Blue Earth.
what's that? Is there another one?
Blue Earth.
Blue Earth. Okay, thank you, Blue Earth. Let's start with Chuck Snyder.
Hi guys. So I just wanted to give you an update on my lymphedema. I think I mentioned a couple months ago that I after I completed chemotherapy, 10 rounds of chemo, I developed this lymphedema in my left leg that it got pretty bad. After I think it started like around the 8th round of chemo, and then it continued. I had it in both legs actually. And the lymphedema or swelling in my right leg went down, but my left leg, it continued to bother me, and it got worse and worse. My leg, and ankle and foot were swollen pretty badly. So I ended up going to a physical therapy, a certified lymphedema specialist, and it really helped me a lot. I'm so happy that, you know, they were able to basically they call it lymphatic drainage, where they, massage your lymph node. Well, let me go back. I have cancer. My cancer is in my lymph nodes. I forgot to mention that. So, but I'm not really sure if the lymphedema was caused by cancer in the lymph nodes or if it was just due to the chemo. But anyway, going back to the physical therapy, they do a lymphatic drainage where they massage your lymph nodes and your behind my collarbone, and then they go down to your armpits, and then your abdomen. They start with that, and then they massage my leg. I had a severe swelling in my thigh. They did some massaging of the leg, and then after that, the last thing they do is they wrap my leg, starting at the ankle, or pretty tightly down below, and then all the way up to my thigh, to the very top of my thigh. So it kind of forces the lymphatic fluid up into my abdomen. But anyway, I'm really happy it's really helping, because my leg swelling has gone down quite a bit, and got to the point where it was so uncomfortable and starting to hurt. I couldn't walk. So I'm just hoping that it's not going to be a permanent thing. They say once you have lymphedema, you'll have it for life. But they're after they get the leg down to the final normal size, they measure your leg, and they order a custom sleeve, compression sleeve, which you're supposed to wear, when you stop the physical therapy. So hopefully it's not a permanent thing. But anyway, just thought I'd share that information with everybody.
Chuck, did you have any lymph nodes surgically removed?
No, I didn't. I just have cancer mostly in my abdominal lymph nodes, and I asked my oncologist, could they be removed surgically, and he said there were too many of them and too many lymph nodes to remove. So he just said, you know, what do you call it? Systematic there, yeah, the Orgovix
Systemic?
and systemic therapy is the best way to go. So, yeah.
Okay, anybody want to comment to Chuck? A question?
Did
Jerry?
you, Chuck, did you have any radiation to your abdominal lymph nodes?
Actually, no, I didn't. I just had radiation on the prostate and seminal vesicles, seminal vesicles. But no, I didn't have any radiation done. I yeah, I thinking back, initially when I was offered radiation, my lymph nodes weren't that bad, and so the radiation oncologist thought it wasn't necessary to do the radiate the lymph nodes. So he just did the prostate. But I wish I had wish I had done radiation to the lymph nodes. Maybe it would have avoided this whole problem. But on the other
Well,
hand, oh, sorry.
the reason
Sorry.
why I asked that question is I just went through the external beam on my lymph node, so I was just wondering. Thank you.
Okay. Okay.
Chuck,
Yeah,
when did you
maybe
finish chemo?
in July 10th. Yeah.
So, Gary Burr, it's not usual to wind up with lymphedema from radiation, but it does happen occasionally. More likely, sometimes from surgery if they mess with some of the lymph nodes, and we've seen it where people have swollen up pretty badly. We've seen it with radiation, but I bet Len or I we're pushed to think about when it's happened, but it's happened. Now, what's interesting is that it's very common in breast cancer, and so breast cancer has been focused on lymphedema for the longest time. When I say the longest time, I mean before 2007, because I've worked with some of the academics who recommended exercise for lymphedema. And I'm not sure what the role is now for somebody like Chuck and if exercise can help, but we definitely know that exercise helps the women where the lymphedema is more around the chest and under the arms. So it doesn't at all surprise me, and we may have even suggested it, Chuck, I can't remember, to check for a physical therapist who specializes in lymphedema, because it's a very popular, it's popular with the ladies and the men who suffer from breast cancer.
Chuck,
Yes.
I had it at the end of my chemo. I think it's pretty common with chemotherapy to have this, particularly toward the end of the cycle. I mean, it affected me, my legs, or one
Okay.
leg particularly.
Okay.
What did you do, Peter?
I did massage and it went away. It didn't hang on. It freaked me out though. It's pretty weird experience, that's for sure. See your leg turn into like an elephant or something. Yeah.
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 And they never prepare you for it. They never tell you could well happen with chemotherapy.
No, that's exactly right. And I told my the oncologists, they don't really care about side effects. They more concerned about just killing the cancer. But anyway, he did suggest I go to physical therapy, which I
Good.
did do.
Okay, thanks, Chuck.
You're welcome.
Jerry, you wanted to speak?
Yeah, thank you. Actually, I've missed quite a few sessions here because of all the treatments I've been receiving, just to bring everybody up to speed. Vietnam veteran, which so subject to Agent Orange, I'm in 100% disability because of that, and it was diagnosed 4 years ago in 2018 with Gleason scores 9. I went through high dose brachytherapy, external beam radiation at that time, and 2 years of ADT. So here very recently, in the last 3 months, my PSA started spiking upwards. I had a PSA scan, and it showed that the cancer was back in the prostate and in lymph nodes in the pelvic area, lymph nodes in the pelvic area. I went through with Dr. Sue at UCSF. I went through 2 sessions of high dose brachytherapy again, and 5 sessions of external beam radiation aimed at the lymph nodes that they saw that were cancerous, and did 1 month of oral ADT, and now I'm back on the injections, due for another one the end of January. So my question to the group at this point is, and I've asked this question to the radiation oncologist, I haven't met with Franklin Hong yet, who is my medical oncologist. I see him next month, and my question to the group basically is, I've asked the question is, what do we do now? And he basically says we just monitor PSA and see how we're doing. And I'm kind of wondering if I should get more, another PSA scan, or what I should do at this point. I'm open to suggestions about what everybody feels like I should do at this point. Thank you.
So just let me understand again. They did high dose brachy and IMRT, and your original treatment when you were first diagnosed, that was your original treatment when you were first diagnosed, the high dose brachy and the IMRT?
Yeah, I went through 25 sessions of external beam radiation
Right.
when I was first diagnosed, and then plus 2 years of ADT. At that point, my PSA was, undetectable.
Yeah, and then what did you just do now? What did they decide to do for you right now?
Again, Dr. Sue at UCSF did 2 sessions of high dose brachytherapy and 5 external beams pointed toward the lymph nodes that the PSMA scan showed.
Okay, this is where I'm getting confused. So where did they do the 2 doses of HDR to?
Prostate, because it had returned, the cancer has returned to the prostate gland again.
Well, that's pretty interesting, since they did the high dose brachy there originally, and it's come back to the prostate. We don't hear about that too often. We do hear about it if they do focal therapy, but you didn't have focal therapy originally. You had the works. You had pretty much what I had, except I had seeds and you had high dose.
Well, you're sounding exactly like Dr. Sue at UCSF. He goes, I am shocked that this has come back to your prostate.
Wow. I mean, that's really amazing. Did they, what was your original Gleason score? 5+4, right? I have that down.
Yes.
And what does it show up as now? Did they biopsy it again, or have they tested it again?
They have not.
Yeah. Yeah, I mean, that's, anyone else heard of that? A recurrence after high dose brachy to the gland?
No, I never heard that before. And as he was telling the story, I was thinking, okay, great. He had the recommended standard of care, best treatment, high dose brachy with EBRT boost. So that's disappointing. But what's even stranger, I think, is that they would radiate all the same areas that they did the first time. Usually they don't like to do that. Did you have any
And
side effects after the second round of radiation?
Yes, it has. It definitely it has affected my bowel movements and some of my urination. But I would not call it extreme. I'm putting up with it, but I live with it. I think that's exactly what happened when the first round of radiation
right.
happened. So it's no worse than it was prior to that.
And where did they do the SBRT to this? You said they did 5 sessions of SBRT. Where did they do those to?
They tried to locate or radiate the lymph nodes that were shown on the PSMA
Got it.
scan.
Yeah, yeah. So they did 5 sessions of SBRT to the lymph nodes. They did another couple of sessions to HDR. And how long are they saying you'll remain on the hormone
ADT.
therapy?
Well, I asked that question also of Dr. Sue, and he said it was really up to the medical oncologist. He said, each one of them has a different, idea of how long to be on the hormone therapy. But so far, I've been on it for 2 months, but I'm scheduled for another quarterly injection here in January.
So, are you being treated through the VA in San Francisco or through UCSF?
Basically, that's a very good question because I am a veteran, but I am being treated at UCSF at the same time. So it's kind of like uh, a mixture, but UCSF, I would say right now my treatments have been mainly UCSF. I mean,
Yeah,
yeah,
but how
UCSF.
did you get to UCSF? Did you get to UCSF through the VA or did you get it through there privately?
No, absolutely through the VA.
Okay, so you're being treated by the VA. Now, that is important. The first thing is, if it were me, I wouldn't be taking more injections, I'd be taking Orgovix. And you can get Orgovix through the VA, no problem. And I
No,
don't know why they never put you on Orgovix in the first place. And you can
no,
say,
Rick, I did,
should be on Orgovix.
they did put me on it for 1 month. And I asked that question, why didn't I stay on that to Dr. Franklin Hong? I asked him that question and he says, well, we actually have more data on the injections than we have on Orovix. So,
Yeah, that's bullshit. I
okay,
mean,
thank you.
they do because the Orgovix has been around a lot less, but the fact is that you're going to recover much quicker on the Orgovix. So tell them you don't want any more injections, you want the Orgovix.
I will
Because
bring it up.
anecdotally, and you can say we realize it's anecdotal because the Orgovix hasn't been around as long, but anecdotally, men are recovering their testosterone much quicker. And so, and it's easier for you. You take your pill every morning, boom, and then when you want to come off, you want to come off. But he knows that too. So that's the first thing I would say. The second thing I would say is, since this is a recurrence, are they planning on giving you any other ADT, like a second line anti-androgen, like enzalutamide or dutasteride or abiraterone?
I also asked that question, and that was referred. I asked it to the radiation oncologist, Dr. Sue, and he says, ask that question to the medical oncologist, which I will. I have a meeting coming up with him in January. So those
Right.
two good
So,
questions. Two good questions.
and I think he's a good, I don't really know him, but I know of him. I think he's a good guy, but I think and we lost Len because his computer froze. I don't know when he'll be back. So the protocol today is to add a second-line anti-androgen. Now, which one and debatable, but it is to add a second-line anti-androgen when you recur, because you have recurrence and you have recurrence in the lymph nodes, and when it comes back now, we don't just treat it anymore with one, we treat it with two, what's called doublet therapy.
Yep.
So you should be asking Frank, what's his last name again?
Hong. Huang.
That's it. Yeah, I knew the spelling was. You should ask Frank Hung, and if I'm not mistaken, he's been working at the VA for the longest time. He's a UCSF medonc, but he's really spent a lot of time at the VA. And you should say to him, well, isn't doublet therapy appropriate now? And ask him, because I can't tell you what to do, but we can tell you what the protocol is.
Thank you, Rick. Appreciate it.
Anyone else want to chime in for Gary? Or correct me?
Yes, this is Frank Fabish. I'm a VA veteran. All of my problems and cancer have been from Agent Orange. I use community care to go outside the VA to the James Cancer Hospital at Ohio State. And I am getting Orgovyx through the VA without any problems at all. And my second line treatment right now is abiraterone with prednisone. And I was on darolutamide, but my PSA started rising and my nodules in my lungs started to grow. And my GU oncologist recommended that we change the second line ADT, but he kept the first line, the Orgovyx. And I've been on it now since Orgovyx since March of 2021. And it has worked successfully for me, and it replaced Firmagon injections, which were effective, but to me were painful. And I was pleased to be able to go from the injections to a daily pill and not have to go to 28 days back to the doc to get the injections. So through the VA, you can get those drugs. And as Rick said, the doublet therapy is much more effective.
Yep. So, I think, I mean, you're on it. I'm impressed, Jerry. I mean, you're on top of it. You just got to keep pushing these docs. I mean, the good news is that the Orgovyx is probably more easily available through the VA than it is through the private system. And so you should be able to get it. And then it's Dr. Wang's call as to whether to give you the doublet, but I think if it were me today, that's probably what I'd be asking for. If he can put you on dutasteride initially, you're probably going to feel best for that. But if he puts you on something else, you'll deal with it. Peter Kafka.
I just have a general question regarding Orgovyx. For guys that have been like Frank, you've been taking it for quite a while, almost 2 years now. Do you experience breast growth like you do with Casodex or with those, which is a similar drug?
I've not experienced it at all.
You shouldn't do, Peter, because it works like an LHRH drug. So it doesn't work like a Casodex or enzalutamide or those other drugs.
Right, but you don't have to take Casodex
Yeah,
initially
but
with it.
that's
Okay.
a completely different issue to
Okay,
the
good enough.
to the
That answers it. Yeah.
yeah. Now, go ahead, Neil Sundstrom.
Yeah, I just wanted to say I've noticed quite a bit of waist growth and somewhat some breast growth. I've been taking Orgovix for, but not breast growth necessarily. Maybe that's just part of the waist. It's gone, and my stomach's gotten
Right.
puffed out quite a bit from the Orgovix. I've been taking it since April.
So that is a side effect of all the LHRH drugs. And we know that you put on this belly fat unless you work very, very hard to stop it. And I know you exercise like a phenom, Mr. Sundstrom. So I know you're exercising. I mean, I put on over 10, 12 pounds and I don't have a big frame. And it's really hard to stop it. And that has to do with your metabolism slowing down. You're probably hungry a lot of the time, so then you snack and you snack on the wrong things. The stuff to snack on are like celery and carrots, the boring stuff. But it works. It does work. They fill you up. But that said, yes, I think everybody in this room who's been on long-term hormone therapy has probably experienced this thickening around the waist. And we have to work hard to stop that. That's a different issue from the gynecomastia. And the gynecomastia can arise when you start with some of these second-line antiandrogens. I guess Len's texting me here, and so I think he's still without service there. I should tell him to come in on the telephone.
Pardon me, 1 second. Jerry, are you aware of the Veterans Call the last
Yes,
Thursday of every month?
yes, and I have been on that a few times. Yes, I just need to say that with all the treatments I've received here lately, my schedule has been just wow, it's been crazy. But I am participating. Yes, thank you.
Okay.
Thanks. And we're now led by our fearless leader, Captain Jim Marshall, and we will talk to you about all of your benefits and everything else in that one. We won't be talking about whether you should be on Orgovix or Firmagon or Lupron or anything else, and how best to save the VA money, but we will be talking about how the VA can spend their money on Jerry Burr. Okay. Anything
No,
else
no,
before
no.
we
I just want to say
move
thank
on?
you all. I appreciate the input.
Pleasure. Okay. So the next person up, according to my man in Venice, is Spencer.
Oh, hi. I'm here. I was here
Okay.
anyway. Yep. Um, I, I finished. Well, just to go a brief summary, I was diagnosed a year ago, October, and I've been on the anti-androgen therapy, uh, the injection with the Lupron and abiraterone. And and that was working fine for a while, and then my PSA started going back up again. It was down to probably about 2.5, and then at one point it started spiking and it went up to 8. Um, I he changed me. He took me off of the abiraterone, and put me on what's that? What's the thing with the D again? Darolutamide? Uh,
Dutasteride?
Darolutamide.
Dutasteride?
No,
Dutasteride?
no, darolutamide.
Darolutamide.
Yeah,
Darolutamide. Sorry, yeah.
right,
Go ahead.
right. And also they gave me a round of radiation of 16 treatments of radiation, and that was mainly almost more palliative than treatment, because I was having a lot of pain in my rectal pain, and I had I had a really big tumor right at the head of my rectum, and they wanted to get rid of that, and the radiology, radiological oncologist said, we can go for more than that. Let's just see how much how much of the cancer we can treat with this. So I had the radiation. I completed it about a month ago. And I'm in more pain now than I was then. I guess I don't know, the radiation has really caused me a lot of rectal pain, and the doctor said, yeah, that can happen. You just have to wait it out. It'll get better, and it has been improving, but it's still pretty bad when I sit down. Um, but you know, I'm living with it. However, I just had an appointment with the oncologist on Friday, and my most recent PSA went down dramatically. It went down from 8.3 to 0.4. So I'm very happy about that. And I don't know if that's a result of the darolutamide, changing from the abiraterone to the darolutamide, or the radiation, or a combination of both, but I'm happy about it. Um, and I don't know, you know, and if once the pain in my rectum goes away, I'll be good, I think. Uh, we are planning on a trip to Mexico in January. We do this every year. We go to Puerto Vallarta, and we stay for 2 months. We stay from beginning of January to the beginning of March, and I was very nervous about doing it, but I'm doing it, and I think I'll be all right. So.
Well, a couple of things. And I think I'll make a note to connect you with Jerry Pelfrey, because Jerry's not on tonight, but he spent a lot of time living in Mexico with advanced cancer. And so there may be issues that you need to be aware of, or medicines that he suggests you take with.
Well, I intend to take an antibiotic in case I get a UTI. That's the thing I'm mainly concerned about. I have no use. I cannot urinate at all. I have a suprapubic catheter that I've had for about a year, and
Right.
that's the way I urinate.
Right.
And I have had instances where I get a UTI from it, and I take antibiotics and I'm fine. I had one incident where the UTI threw some blood clots, and it clogged up the catheter, and that was pretty bad. I had to go to the emergency room, and they had to change the catheter. And another time where the same thing happened, but they didn't have to change the catheter. They just irrigated it, and
So
it cleared it up.
a couple of things just to check with you. Who are you talking to about this continued pain that you have in your rectal area?
Well, I've been talking to Dr. Tester, the oncologist, and I have an appointment with the radiological oncologist on the day after Christmas, the 26th. So.
Okay, so you're going to have some discussion about possibly radiating that area.
No, I did. That's what I did. I just went through the radiation for
Right.
that area. Yeah.
So what's the discussion with the radiation oncologist for? More radiation?
No, I don't know. I just want to find out how long should I be suffering with this? Why am I still having symptoms You know,
Okay. Well, what does Tester say about it? I mean, it seems like they're throwing this around like a hot potato between the
well,
the medical oncologist and the radiation oncologist.
well, he's not throwing it around. He just says, you know, this is to be expected. It happens in some people. You had pain before, you know. Sometimes you get this kind of pain with the radiation, and it takes a while for it to go away.
Okay.
So
Have you got a palliative? Did you talk to him about getting a palliative care doc on your team?
no, you did tell me about that last month, and I forgot to do it. I should be. I will do that.
Okay, you got to do it because they're the guys who can help you manage this pain. You don't need to be in pain,
Okay.
and their job is to help you manage it. So, and make sure he understands you're not asking for hospice care. You're not talking about end of life. You're talking about quality of life
Right.
and
Right.
system. And you want a symptom management doc, a palliative care doc.
Mm-hmm.
These are all euphemisms for the same.
Okay.
And get yourself, call them up tomorrow and get yourself a consult with one of them very, very quickly. Also, I recommend that you talk to the docs at some length about your 2-month trip to Mexico. Have you spoken to them about it?
Yeah, I talked to Tester about it, and he's okay with it. He's a little nervous about it, but he seems okay with it. He asked me all kinds of questions about what kind of medical care I could have down there, and it is pretty good. Um, their medical, they have a couple of good hospitals there. There's a lady that I've been in contact with for several years that's a medical consultant, and she's been very helpful. Last year I went for 5 weeks last year, and I did have the catheter then. And before I went, I checked with her to make sure that I could have care if there was a problem with the catheter, and it would be something that I would need immediately. It would be an emergency, and I'd have to have it immediately. And she said it's not a problem at all. They have doctors, they have a hospital, and
Okay.
that they can take care of.
And
And a couple of
last
years.
question.
Oh, yeah,
What
sorry.
what what did Dr. Tester say about Provenge? You were going to discuss it with him.
Oh, I didn't. I'm sorry. I should have done that.
Spence,
Yeah.
you don't have to apologize to us.
I know. I should have.
Okay, so you got to talk to him about the Provenge. You got listen,
Proven.
and this is for
Remind me.
everybody.
Okay.
When you're going in to see that doc, please make a list of everything you want to talk about ahead of time.
Yeah.
Write it on a piece of paper. Take that piece of paper in with you and give a copy of it to the doctor.
Hmm.
Don't rely on you remembering everything when you go in there because you're anxious, you're nervous, it goes out of your mind. And I mean, listen, stuff goes out of my mind. I'm talking to David Muslin and I can't remember what the hell I want to say to him. So it's not unusual. You have to be your own best advocate.
Yeah.
And to be your own best advocate, you've got to write this stuff down. The other thing is put it on an email, put it on a note, a message in the portal, not an email, but a message in
Yeah.
the portal,
Yeah.
not an email, but
That's what I'll do.
using the portal.
Yeah.
Write it all down there, and then you remember. Oh, I got to talk to him about Provenge. I got to talk to him about palliative care. And if he's got that piece of paper in his hand, or she, they're going to stay with you until they've covered it. They won't
Right.
give you the bum's rush.
Right. Now, remind me again. Provenge is immunotherapy.
Provenge is the original immunotherapy that uses dendritic cells.
Uh-huh.
And the time to get Provenge is before your PSA gets too high. There are
Okay.
doctors who feel that it isn't the best, that it doesn't work. There are other doctors who think that it really helps, but you don't see the effects like you might do. So you won't see your PSA dropping because of the way that it works.
Okay.
but we recommend, it is standard of care. We recommend that all our guys discuss it, and that if your PSA is not too high, what the principal investigator, Larry Fong, calls you have a long landing strip, it could be right for you.
Okay.
I'm handing back to Len.
Okay, thanks
Okay.
for taking over, Rick.
Yeah.
Just one
Well,
question for Spencer. Anybody recommend glucocorticoid suppositories like dexamethasone, anything like that?
no,
Rectal? No?
no. What is that? That's,
Well, sometimes they'll prescribe that for radiation proctitis. Um, so it's just a steroid that is anti-inflammatory. Maybe that'll help your rectal pain. I don't know, but talk to them about a
oh, okay.
prescription.
Yeah. Give me the name again.
Just a
Gluco.
dexamethasone suppository. I can put it in the chat, or somebody
Dexamethasone.
can.
You could just call it a steroid
Steroid
suppository
suppository, yeah.
Steroid suppository.
for spelling simplicity.
I do have I do have a cream that I've been taking. That actually I was taking it since I had hemorrhoids. It's a lidocaine cream, and that
Right.
does seem to help. That does seem to help a bit.
Yeah,
But yeah, I will.
that's a painkiller, but the
Yeah.
steroid is anti-inflammatory. So you could use
Okay.
both.
Okay. I will definitely ask about that. Thank you.
All right. So Rick, we after Jerry Burr, you went to Spencer. Is that right?
Oh, can I
Yes.
ask one more question?
I just want to
Hold on,
add
can I ask
one
question?
more.
Yeah, I just have one more question. You were
Yes,
talking about
Spencer,
the.
I
Yeah.
just wanted to add one more thing, which is that I had fairly intense radiation proctitis, and
Uh-huh.
what helped me a lot was sucralfate enema.
What kind of an
Oh
enema?
yeah,
It's called sucralfate.
yeah.
Sucralfate.
That's
Okay.
also a suppository.
Okay. All right. I will ask about that. Sucralfate.
SUCRALFATE. Sucralfate.
Yeah, put it in the chat window, please, Ravi.
Okay,
Okay.
sure.
All right. Let's go to Peter Kafka and then Jeff Wood. Go ahead, Peter.
Okay, good news is I had a blood test Friday, and my PSA is still holding pretty good. Hasn't budged much. So I'm 5 months now. In 2 weeks it'll be 5 months off of all treatment. So still a happy
Terrific.
camper. And with that, I do have an issue that's unresolved. The quick backstory is, because I did immunotherapy, the Keytruda, my last dose in July really did a number on my intestinal system. It was went back and forth between diarrhea and constipation and stomach cramps and this and that. So we pulled the plug at the end of July and decided not to do it. And I went on prednisone and off of prednisone. So, but I still had stomach issues, pain and a little bit of cramping and stuff after I eat something. So that led me to say, maybe I should do a colonoscopy, because I usually do them every couple of years or every year. And so I had a colonoscopy 2 weeks ago, and that came back negative for no big issues there, no polyps or anything, a little bit of diverticulosis in one area, but nothing terrible. However, since then, the last couple of weeks, I've had extreme diarrhea. I mean, big time. So that I've really got I'm just I've really got to watch and not eat. I don't eat much anymore. I'm panicked about it because I get caught in strange places without bathrooms and this and that. And um, I just, with my blood tests on on Friday, we did a whole stool analysis and looked for bacteria. I went back to my surgeon, and he thought maybe I picked up bacteria in the hospital doing the colonoscopy, but it all came back negative. All the tests came back negative, so it doesn't seem to be bacterial related that I know of. I'm going to meet with him again on Thursday and see what I can do, but it's got me freaked out a little bit. Because all I can think of is it's related to the colonoscopy. There's no blood. It doesn't seem like anything was punctured in any way. But it's just got me spun around a little bit. So I'm not looking for answers. I'm just kind of reporting in, and hopefully I'll find an answer to this. I haven't really taken any Band-Aid meds, the stuff you take that's Imodium or any of that stuff yet. I'm just kind of dealing with it with very limited diet and keeping my fluids up and just trying to take care of myself. But it's depressing, to say the least.
What did the GI doc say? What's the GI doc said?
There is no GI doc, and there is no GI doc in Maui. I'm thinking of flying back to Minnesota if I have to do that.
Okay, so who did the colonoscopy?
Surgeon, general surgeon, who's done it.
The general surgeon.
This is about the third one I've done with him. Yeah.
Okay, so that's the doc, and that's the doc that you've been talking to, right?
Right.
So my suggestion would be sooner rather than later to get a GI doc involved, however you can do it.
Yeah, I've got to figure that one out. I know.
How about Honolulu? Is there any?
Yeah, it's possible, but the standard procedure here, you call a doctor up any place in the islands, and it's usually like a 3-month wait. So I've got an apartment and a car. I might fly back to Minnesota and deal with it back there if it still goes on, and it remains a mystery.
When you were traveling all around last summer, you stayed in the United States, Peter?
Yeah, I did go up to Canada for 1 week before I saw you.
Oh yeah. I mean, if you think worldwide, there are exotic causes of diarrhea that we don't ever think about here. Campylobacter and all kinds of other things.
Well, Campylobacter came back negative. All those things. Ciguataria. There's a reef fish disease you can get here. There's all kinds of stuff.
You did get tested for weird stuff.
I got it all the other day. Parasites, you name it, all negative.
Better get out the Imodium.
I could, but that's the Band-Aid approach. I'd like to.
Yeah, it's a Band-Aid until you get.
I don't know. Again, I don't know whether this goes back to my immunotherapy, which kind of messed me up, or whether it's related to, coincidentally related to the, because you wipe out all the good stuff when you prepare for a colonoscopy. So I take probiotics.
You do.
Still.
The best way to take probiotics is not in a probiotic pill, but in fermented foods.
I take the yogurt with it.
Yogurt and
do that.
Kimchi. You
gotta watch it with spicy stuff like kimchi.
I know. That stuff kills me. I try to take it, but miso. That's a good way to take probiotics, and there might even be GI cancer implications for taking probiotics that way. If your idea is true that you cleaned out all the good bacteria and have to recolonize, but it sounds like you're already eating yogurt.
Yeah, but I just can't keep much down. Yogurt, all that stuff goes right through me.
You keep it down, but it goes right through you.
Jack, did you want to contribute?
No, there's no nausea. I'm not
It's,
sick. I don't have nausea. I don't have fever. I don't have any symptoms like that. It's just straight diarrhea.
no, I was just going to add the whole thing about the microbiome and doing whatever you can to, strengthen it, with good life, probiotics and whatever you can get the best kind, and a lot of fiber and feed the probiotics and really get a high quality one. I don't know what you're taking, but it sounds like the microbiome's a little off.
Could be.
That's what I would do if I were in your shoes.
Okay.
And David Muslin has his hand up.
Yeah, I was just going to say, Peter, um, that I've dealt with a lot of stomach issues and Crohn's disease, but your quality of life is going down, and a little Imodium or Lomotil might just quiet everything down too. I know it's a Band-Aid effect, but at least you can go out and live life a little bit, and maybe that'll help. But I just feel bad for you because I know what it's like to be afraid to not be near a toilet, and
Especially with Christmas and New Year's parties.
yeah. So just
Oh,
try a little Imodium and be really, really
Right.
careful. And dairy
Yes.
products, when your colon's upside down like that, dairy is not real healthy.
No.
Just some
eggnog,
real
eggnog and
bland, simple
fruitcakes.
food.
I usually stay away from dairy. I use cashew
Right.
probiotic cashew stuff.
And everything's got to be cooked. No raw veggies, no salads
Right.
for a while. Just let everything quiet down. The Imodium might quiet down, and then you might start feeling better. It's just a thought.
Okay. Yeah, it sure affects your spirits. It's amazing how it can depress you when you've
I have a motto: never pass up a good bathroom. I know where every bathroom is. Seriously, wherever I go,
I do too.
I know what it's like. So
I know.
I do know what that's like.
Someday we
Peter
can
had,
trade our most embarrassing stories. We could probably
Peter knows every bathroom in the whole quadrant of San
on the BART
Francisco.
system. Yeah, on the whole
Yeah,
BART
on the
system.
BART system, that's it.
I once had to run into one on the way to UCSF, and they told me I went to a coffee. Go upstairs on the street. I go run into a coffee shop. They say bathrooms only for customers. So I pull out a $5 bill and I said, "Here, where's the bathroom?"
Oh boy.
We could share a lot of stories. A lot of stories.
We can.
Okay, so Len's new fancy internet in his new apartment is really playing up. So he'll be back with us whenever he can. In the meantime, anyone else have anything to contribute to Peter before we move on to Jeff Wood and then to Ravi? Okay. Jeff Wood, you the man.
Good evening.
Good evening.
I could use some help with, standard of care for my situation. And just a quick recap, surgery, radiation, 2 years of ADT. And I know last week we talked a lot about ADT and how unpleasant it is, but I did do 2 years of it. And then I did get 4 years out of it afterwards. A year and 8 months with no rise, and then the last 2.5 years with a slow rise. But now I'm at 0.62. I just had a PSMA PET scan that came back negative. And I'm just wondering, we talk about standard of care a lot, and I think maybe it moves around. It might be a little bit of a moving target, and I'm wondering if, where is my standard of care at this point?
I would just add to that that Jeff's doctor has chosen a PSA of 1.0, I think it was, Jeff, for when he's going to
Yeah, it's kind of,
initiate.
Kind of up
treatment,
to me, but that's kind of where we're at right now, is at 1.
and Jeff is a 4+3.
So it's a shame that Len isn't with us. I'm gonna text Len again now and tell him to call in, because
Yep.
he's done more of this back and forth on and off than probably any of us. And so I always appreciate his input when it comes to going on and going off. And I'm just saying, hold on, please, please call in. So,
Maybe as a side issue, I was also trying to determine, that I believe I'm non-metastatic hormone sensitive, but it
yeah,
was out, I had it in one lymph node, and I had it on semical vesicles, some invasion there, some involvement. So I think I'm still
originally.
non-metastatic.
Right. So I think the first issue is that we're not seeing. You had a PSMA last week, and your PSA was at what level, Jeff?
0.62.
And so we're not seeing anything on your PSMA scan.
No.
And who read the scan? Where was this done, and who read the scan?
It was done at Hackensack Hospital, which was read by radiology, the radiology department. I'm going to get a copy of it.
Again, some of this bothers me because did you ask how many they've read before?
No, I didn't question them. They said they've done quite a few. I think you mentioned on this call before, with Clarify, you can get that read somewhere else, right?
Well, we thought you could, but it turned out you couldn't. They told us you could, but essentially all it was a service to help docs who read them get some assistance. So your doctor can call into Pylarify and get that help, but it's not available to patients. And frustrating is that we still can't nail it down with SNMMI to get second opinions on these PSMA scans. Have you set up another doctor, GU medical oncologist?
Yeah, I've got somebody that's Dana Rathkoff is kind of my secondary or my second opinion right now.
Right.
Until I get.
So I think.
Go ahead.
I think what I would do is set up an appointment sooner rather than later with Dr. Rathkoff. Tell her you got a reading. You're not super confident in that reading. You'd like to come in and talk to her about how she would handle this treatment because you're at a point, and you'd like to get your PSMA scan read by somebody over at MSKCC, because they do have a lot of experience reading PSMA scans, because they were involved in the trials. And I think that's probably what I would do. The standard of care is probably the standard of care is to go back on hormone therapy. How much and what hormone therapy? I think it's difficult. I really don't know if they can't see anything. If they see something, I can tell you what the standard of care is. If they can't see anything, I'm not really sure what the standard of care is.
Jeff, you
And
had surgery or radiation?
Both surgery followed by, and then radiation quickly after.
Aha.
Within a month, my PSA was rising and right to radiation in ADT.
And then what did you do? IMRT radiation after that?
Yeah.
Interesting. Sometimes if the spread is in the prostate bed, because you said it already spread to the seminal vesicles and stuff. I mean, sometimes the PSMA is not great at picking things up around there, where the prostate was and stuff. Not as well as further out in the lymph nodes or other organs and bones and stuff.
Jeff, it's
Ravi.
David Muslin. How fast is
Oh, go ahead.
your PSA rising?
So it took, after a year and 8 months, then it started to rise, and it took 2 years and 6 months essentially, or 2 years and 4 months to get to 0.62. So it was like over the course of a year, it would kind of double.
Asking the brain trust, that's a pretty slow climb, isn't it, guys?
Yeah.
It's a very, very slow climb, and it's a Gleason 7 case, although high intermediate. And so it's a little bit unlike the one we talked about an hour ago, where somebody was a 5+4, had recurred, and we recommended, or at least recommended the person inquire about 2-drug therapy. In this case, does he need 2-drug therapy with such a slow cancer? His doctor is already acknowledging how slow it is by waiting until it hits 1.0 to pull the trigger.
It's almost a good thing, and he might, it sounds like it's a good thing, and he should enjoy himself until then. You seem worried, Jeff. Are you worried?
No, I've been, but you know how it is watching things go in a direction for
Yeah.
for 2.5 years. I've been watching it,
We do.
waiting to get to a
Yeah.
PSMA, PET scan so I can see where the hell this is.
Right.
Happy that it's nowhere. Happy.
Right.
I mean,
and that you're still
that's-
hormone sensitive is pretty amazing too at this point.
Yeah.
I mean, that's exactly why I said I really don't know what the protocol is right now, because we can't see anything. So, Dr. John makes a good point. I don't know if you'd go in, with all barrels firing, if we didn't even see something. Sorry, Len's making me a little nuts here. Ravi, you had something that you wanted
No,
to say.
I don't. The subsequent conversation answered my question. Thank you.
Oh, okay. Anybody else have anything that they want to say?
Rick, I'm just wondering, because this sounds so familiar. What about the color Doppler? That's the thing that Peter Carroll wanted me to do. And I wonder if this wouldn't be useful at this point for him to have a color Doppler just to see if the pelvic in the prostatic fossa is still have anything hanging out.
Well, there's a couple of issues there. The first is that you got to have somebody who's really good reading that color Doppler.
Right.
And Dr. Shinohara is in San Francisco,
Yeah.
and I don't know anybody who's a color Doppler expert in New York.
Nobody.
Would something show up on the PSA? I mean, the other thing is, we don't really know did anything show? I mean, did they tell you if you were PSMA avid or not?
Yeah, that's a good question. That was one of my questions is how do you know? I'm even expressing it, would express it. How do you test for that?
Well, you can't, as Dr. Jack will tell you, it's very, very, very difficult. But what you could do is you could try an Axumin scan, because that works in a different way. And an Axumin scan might show something where a PSMA didn't, and then you'd know you were not PSMA avid, because there are a number of men who are not PSMA avid. So
Yeah, I had one of those. I had one of those. Right at the after surgery, I had one before radiation.
Right. So, but I think this is all good stuff to talk about with Dr. Rathkop. So an Axumin scan could be on the table, getting the PSMA scan reread. Are you PSMA avid? And then, once we've gotten through all of those, then we can say, well, this is what the treatment could be.
Yep. Well, I got to make my appointment with her.
Is anyone else in a similar situation? Okay.
Isn't Len in a similar situation?
Well,
Len
can't call in because he can't open his laptop, which is overheating. So I've got to try and make some time here to text Len the number, to send him in. And the way I'm going to do that is Ravi's next up. And Dr. John, would you moderate for a few minutes? Ravi, we need to make Ravi a presenter. Ravi wants to show us reveal his inner self to us. and so we're all going to see Ravi's inner self, and I'll try and get Lem back on there. So Ravi,
he's a presenter.
Oh, somebody just did it.
Peter. Ravi, okay. You're a presenter. Now,
you'll
be able to share your screen. Somebody talk him through how to share the screen. I'm trying to do 5 things all at the same time.
Yeah. Only 5, Rick. That's not much for you.
I know. Yeah. Let me just see.
I don't need to share my screen just yet, and I know how to share it. So.
Okay, tell us what's going on, Ravi.
Yeah. So I have had. Wait a minute. This is. Yeah. So let me cancel the sharing right now. Yeah. Sorry. Yeah. So I've had a lot of collateral damage from my radiation that I had way back. It ended in August of 2021. And the first thing that I had was it had affected my rectum. So that was radiation proctitis. And then I started passing blood in my urine. I had a cystoscopy done then, and they couldn't really find anything. I mean, they found a spot in the bladder that was kind of red, and they fulgurated it. So that was it for a while. They suggested that I go on hyperbaric oxygen therapy, which I did for 40 sessions. And then things were quiet for about 3 months. And then the bleeding, the blood in the urine started all over again, copious amounts of blood. And also, there's also debris that was coming out. It wasn't clots. It was some tissue-like material that was then obstructing the passage of urine. So again, I went back on hyperbaric oxygen, 20 more sessions for a total of 60. That didn't do any good. And after that, that was all of that was happening between January and May of 2023. And then ever since then, I've been in and out of the hospital, with obstruction. And then I had another cystoscopy done, which I want to share. That's what I want to share with you all, where they found the bladder neck had been badly affected. And the rest of the bladder seemed to be reasonably fine. There was no problem with the prostate. It was just all at the bladder neck. There was a lot of calcification, considerable amount of necrotic tissue and calcification. And the current decision is now to do surgery, to go in there with a cystoscope and scrape all that stuff out. And if there are some of those are stones, calcified stones, he would break it up with a laser. So that's where I am, and I want to show you the my inner self, as as Rick says. So here we go. Let me share my screen here.
Okay.
Share screen. Okay.
Nothing coming up yet.
Yeah. Window. Okay, that's what I should do, right? Yeah. Here you go.
This could be
Can
a
you see?
first.
Can you see?
Oh, it worked. Good.
Yeah, you're seeing this, right? Yeah. So
Yes.
these are the images from a cystoscopy, and you can see the stones, the calcification here. The greenish grayish stuff here is the probe, and the doctor's theory is that the calcification on one side here is rubbing up against the other side, and that's what is causing the bleeding. And you have some of the from that rubbing up, some of the tissue is falling off into the urethra and obstructing it, or also some of the necrotic tissue. So this is all necrotic tissue here, and some of the harder calcification is right here. Some more of the image here. So that's my inner self. It's been quite a trip. And what is I mean, I would call it fascinating, except that I'm so troubled by it now. Um, the moment I start walking, I mean, at any reasonable pace, if I walk like at an extremely slow pace, it's fine. But the moment I start walking, coming down the stairs or anything, I can feel something going down my urethra, and if I'm not careful, it leads into an obstruction. So I've just about had it now. Now the interesting thing is that the hyperbaric oxygen did well for my proctitis. Um, the proctitis has completely gone away, and the doctor's theory is that it didn't do you good for your cystitis, because all this calcification prevented the HBOT from acting on your tissue. So I have my surgery scheduled for the 19th of January, and I'm hoping that it all goes well. I understand that there is some risk of what do you call that? Losing control over your urine. What do you call that?
Incontinence.
Incontinence. Yeah, that's right. With this, and I'm a little bit confused about. So there are two sphincters, right?
Yes.
So so the doctors showed me, so I can see in the anatomy that the distance between this bladder neck and the external sphincter, this is significant difference. And so the doctor is fairly confident that the risk of incontinence due to something happening to that sphincter is quite low. But then it occurred to me, I mean, I didn't even know that there are two sphincters. A couple of days back, it occurred to me that there are two sphincters, and the second sphincter is the internal sphincter that's very, very close to the bladder and neck. So how about the risk to that sphincter? So that's where I
Well,
am.
that's the sphincter that men who have a prostatectomy live without for the rest of their lives.
Which one, the internal or the external?
The one that's close to the bladder neck, is that right, Dr. John?
Yeah, I think that's how I understand it.
I
We
see.
lose the main sphincter, the one that's mostly under voluntary control. And that second one is really not too much more than a constriction that can be enhanced by the pelvic floor exercises, but is really inadequate to do the whole job by itself.
Which one, the external sphincter is
Yeah.
inadequate? Uh-huh.
So if he messes with that one, I don't think he'll have too big of a problem.
When you say he messes with that one, you mean the internal sphincter?
No, the external sphincter.
Oh, the external one is what seems to be reasonably far away from the bladder neck.
Right. But
Oh, so you mean
what
he's not going to work there?
Yeah, he is going to work in the. Yeah, that's right. So he's not the laser or the knife is not going to really affect some. I mean, he's fairly
there's
confident that the external sphincter is not going to get affected.
right. So when they do a prostatectomy, Ravi,
Hmm.
they basically remove the internal sphincter.
Hmm.
And that's why men have to learn how to be able to control their urine. And many men do, many
Hmm.
men very successfully,
I see.
but not all men, as you
Hmm.
know. So if there is a problem with that internal sphincter, it's going to be the same issues you would have experienced had you chosen to do a radical prostatectomy originally.
Hmm. Hmm.
And common to very many men, and you can talk to the guys some of the guys in this group. There are guys in this group who had issues, and there are guys in this group right now here who didn't have issues. So
I
it
see.
really, really depends. But that's something they talk about a lot in Peter's group. And
Hmm.
Peter, when I'm done, Peter can address that better, and any of the men who are on here.
Hmm.
My biggest concern, and I just want to go on record, is that I personally would not be comfortable with the surgeon you've chosen.
Yeah,
I'm
hmm.
not, let me just finish. I'm not necessarily questioning his technical ability. I'm not saying it's good. I'm not saying it's bad. That isn't the issue. I think that his bedside manner, his attitude, I think you're dealing with a salesman. And there are other choices who are really good, who come recommended by other doctors in the area. And before I rushed into this, because of the fact that there's likely to be complications, if you have complications, you don't want him to deal with you the way he dealt with Jimmy.
Well,
And we met the enemy here.
yeah, I had a long conversation with Jimmy. Jimmy's right here, right? Jimmy
Yes.
Green. Yeah, yeah. So I believe the situation was fairly nuanced. Um, in and Jimmy can speak to it. I don't want to put words in Jimmy's mouth.
Well, the way I understand it, and I don't want to necessarily pull Jimmy into the conversation, but the fact is that in Jimmy's situation, there were explanations that could be attributed to the surgery. And when Jimmy checked around back and forth and finally spoke to another doctor, the doctor said to him, look, we don't know, but it could be this, that, or the other, and we can check this.
Mhm.
But this surgeon didn't want to have anything to do with it. It was his work was perfect, and anything else must be something else, must be someone else's fault. And to me, that's not the sort of doctor I would want. Because if something does go wrong, you don't want your doctor to wash their hands of it. And that's what bothers me, Ravi. I'm not saying he's a bad doctor. He couldn't do this procedure. But when we find doctors here who are not that willing to work with their patients when their patients have complications, that bothers me intensely. And so we can't give you medical advice. I can't even tell you about the quality of this surgeon. I can tell you that in my experience working with other AnCanners, he didn't do a great job.
So you're saying that it's not just Jimmy who reported out on this doctor, but there are others also who had negative opinions about him?
I think there might have been one other person, but I'm not sure. But no, I'm saying that Jimmy's good enough for me. You know, I mean, if one of our guys has a bad experience with a doctor and reports it out to us, then we feel an obligation to tell other people if they're going to go to him, caveat emptor.
Yeah, thank you. But
You
the
know,
impression I got from Jimmy, yeah, anyway, let Jimmy speak.
Yes, I would like to speak. Is it okay if we get those pictures out of here?
Yeah.
I'm kidding. I'm kidding. They don't seem pertinent to this conversation, but that's it's much better. I'm kidding. I'm kidding. It's a tough situation. I'm really sorry for what you're going through. And as I said, just to clarify what I was saying about Cohen, what I've discovered in going through several urologists, an infectious disease specialist at Hopkins, and a kind of an exhaustive search on what were causing these periodic high fevers, which were pretty distressing to me. As distressed, I would imagine, as you are with your situation now. What I finally did come up with was a surgeon, a urologist, who explained to me that there is an antibiotic coating that is used in the artificial urinary sphincter when it is inserted. It isn't given in pill form. It isn't given as pills when you take home with you after the surgery. It is coated in the device is coated with it, and it's called inhibizone, and it's a combination of two different antibiotics. And there are people who are sensitive, who are allergic to this one or both of these antibiotics, and they can have various reactivity. Now, the incidence is low, and so is the incidence of infection that those antibiotics are supposed to prevent. The fact is that no matter how low it is, my feeling is that Cohen, the surgeon that you're talking about, who did this job for me, the fact that he didn't say anything about it on the front end when he did the surgery didn't concern me very much, because it sounds like it's very routine for them to do this. They're trying to protect against an infection, that those drugs are meant to avoid. But the fact that there is a small percentage of patients that are sensitive to it, and that if I was sensitive to it, this could explain what had happened to me. The fact that it was a possibility, I feel, should have been known to him, and he should have referred to it. Then I could have gone and tested for them drugs and see if I was allergic to them. At this point, it's so far behind me, and I have gotten better, that it may not be detectable. If I get any more fevers, I'll probably go and check, but I've had lots of other tests. But bottom line is, if this doctor I talked to said, and he's Indian, not that it has anything to do with you, I told you that, but he said that in India, this antibiotic combination is not used because of the risk that is felt as present of people being allergic and could have reactivity to it. There's also
Jimmy,
speculation. Now, one more thing. There's also speculation that the substantial additional cost that this drug combination adds to the surgery of about $1,300.
Did you hear an echo when I tried to use my phone? Question.
I don't know who's talking.
Yeah, I don't know who's talking.
Yeah.
Whoever's talking.
Yeah, just I'm almost
I
done.
muted him.
Extra cost of $1,300 for the procedure for this antibiotic coating that some studies speculate doesn't really produce any less lower percentage of infection than not using it. He didn't say that, but he did say that they routinely don't use it in India for that reason. None of this
Right.
was said to me. Going and saying this, that when I tried to contact him later, once he decided that his work could not have been the cause of these fevers, he pretty much left it at that and was unresponsive to any further
Okay.
pursuit from me.
So let me sort of just summarize this. Our concern is this. I don't know if this antibiotic is causing Jimmy's issues. I mean, I think Jimmy's being very positive in saying it ain't going to come back, but we've seen it come and go over the past 2 years too often. We can't get to the bottom of it. If the doctor did the procedure and if the doctor used this, the doctor should have said, well, it could be, and not just completely dismiss that his work wasn't wrong. And Ravi, that's where we're having the problem.
It is.
Because if you, God forbid, you've got risks, you just talked about these risks, you may have issues with the internal sphincter, you may not, but whatever it is, and you don't want him coming to you and saying, oh, well, this hasn't got anything to do with me. Your internal sphincter was messed up before because of all the radiation you had. That's not what you want to hear. And I just don't, and there are plenty of doctors who are good, and there are plenty of doctors who are compassionate, and there are plenty of doctors who work with you. And we at AnCan can't give you the medical advice, but we can navigate you to get the best doctor. And if it were me, I would not refer a patient to Dr. Cohen based on how he dealt with Jimmy, either you or anybody else. So that's
Now,
what I want to say.
okay, thank you. I had a second opinion from another doctor here by the name of Susan Terry, who is with Chesapeake Urology. Does anyone know of this doctor?
I don't.
Okay.
I don't. Look, it's just pure dumb luck that I know of Jimmy. But what we did say to Jimmy was, look, go huddle with Dr. Siddiqui, because we really like him. He's a great urologist. It's not his area. And ask Dr. Siddiqui, who would you go to if you wanted this? And that's who he sent Jimmy to. And Jimmy thought the doc was very, very good, and he gave him positive information. So if I was looking for a reconstructive urologist, that's probably who I would go to. There is one other person I'd be happy to talk to. And we can ask Rachel Rubin, who she likes as a I'm sure she has very good input on this issue, and she's on our advisory board, and we can ask her. But for me, I wouldn't. I go to Siddiqui's guy.
I just want to say one last thing. I'm not interested in throwing Cohen under the bus for this. He may have done a fine job. It may have nothing to do with that. But the fact that he did not give me this information, it was not, even when I asked him again, could this have been related to the surgery? And he simply did not, he didn't make an appointment with me. He canceled the one that I did. He didn't answer any messages. And I just gave up on him. And the fact that I had to do that alone, whether his work is good or not, whether he's competent or not, this is the reason. Just points of information. That's all.
Thank you. Has anyone come across this kind of a situation with so much of calcification on the bladder neck because of radiation? Yeah. Okay. Thank you.
I kind of wonder whether some of that might have come down from the kidneys too, because you said there was debris in the bladder, and that's above the bladder neck. I wonder if you have some calcification in the kidneys a little bit, and it got embedded or obstructing or something like that.
I see. Yeah, that did occur to me. No one talked to me about that. I haven't had any problems in terms of kidney function or any pain or anything like that. Now, I did have TURP surgery before all, way back in 2018, and that's the only thing that refers to stone formation and in the bladder neck area. In the literature, that's the only sort of reference to this that I see.
Interesting. Yeah.
Ravi, do you have any kind of urinary retention issues where you can't
No,
pee?
not
No,
at
never.
all. No.
Because I have a friend in Northern California who's got some similar problems, but his manifested as urinary retention. He's been in and out of emergency rooms a fair bit this year because of it. But
Well, the
it
urinary,
seems,
yeah, the urinary.
seems to be due to the same issue with stone type of calcification in his bladder, and he traces it back to his radiation about 8 years ago.
And do you know what he did?
He's still working with it. It's not
I
easy
see.
for him.
Could you ask him if it's okay for me to talk to him?
Sure.
That'd be great.
I'll put my email in the chat window, and you can give me your email, and I'll see if I can contact him.
Yeah, that'd be great.
He doesn't come on our calls, and he's been dealing with this through UCSF.
I see. Yeah, I do need to talk to more people about this. Yeah. So when you say urinary retention, I have had obstruction because of the material coming down the urethra, and that of course leads to retention.
To the point where you had to use catheters or
Well, the catheters wouldn't work because the debris was too large for the.
They couldn't poke through the
Yeah.
through the blockage.
No, they couldn't. In fact, the catheters all kept getting clogged, and when I started using, so one of the mistakes I made was keep keep uh, keep using the catheter, and that led to urinary tract infection. So I've sort of given up on doing that. I just go straight to the emergency room, and then they are not able to do anything there, and I go get admitted. So this is becoming a practice now. Yeah, thank you, Peter. I got your email. Yeah, I'll give you mine.
And let us know if you'd like. I mean, Dr. Rubin is just the best, and she specializes in ED and incontinence issues. She's a urologist, and what I would suggest is we can go to her and we can ask her who she likes, because I don't think she does reconstruction, but we really trust her. She's really great. She's in the DC area.
What's her full name?
Rachel Rubin, Rubin. She's on our advisory board. She's done several webinars for us.
Okay.
And you can find her on the website. Just put her in the search engine and you'll see her. And she's very, very helpful to us. She doesn't take insurance anymore.
I see. I'll set up an appointment with her. Yeah.
But you could set up an appointment with her. By all means, tell her you come from AnCan. She's wonderful. I mean, I don't know. Anybody here has watched her? Jimmy and Jim Marshall, you've seen Dr. Rachel on AnCan, right?
No, I saw her on a Fort Belvoir presentation, and she was wonderful.
Okay.
Gary saw her. Gary's got his hand up.
Yes, I did.
Thanks, Gary. And Jerry and Gary. And so she's really good. But, if really all you want to know is an impartial opinion of who to see as a doctor, she could be a really, really good person because she has the best bedside manner.
Yeah, I will try to reach out to her and find out. Thank you. That's very, very useful. I appreciate it.
Okay, Len, is that really you?
Well, it's the ghost of me. Now that I'm back on my laptop, it says they can't access my camera. I have no idea why. I couldn't join using the desktop app. I had to join in the browser. That's the message I'm getting. So if you want me to proceed without
Well, yeah, I
video,
mean, as I said, it's always good to call in, which is the same as what you're doing now. So if you call in, it's simple, it's easy.
yeah, but
Len,
Rick,
we could have a quick whip around. We could have a quick whip around to get you a new computer. What do you think? David Muslin's our fundraising chair. David, can we handle a new computer for Len?
no. I have the money. Don't worry about it.
I think you should talk to the governor first. Maybe he can
Oh,
resolve
okay,
it.
okay.
I have to
Yeah,
get the governor's clemency.
yeah, we're just ragging you. We're ragging you, Len. We're just giving you
Spend
a
all the
hard
money on haircuts.
time. That's right.
The
You get these
haircut's gone to
haircuts.
my brain.
Guy,
Okay, so
something.
you've done Jeff Wood, you've done Robbie.
Yes,
Okay, so we're going to go to Tom Matica. Go ahead, Tom.
Thomas, are you still with us? Yes. Switch on your mic.
Okay, there we go. Yeah, just listening to the discussion tonight and the interaction of the people in the group with their doctors is kind of painting a picture for me of how I might interact with my doctors. Now I'm relatively new to this situation, and of course I've got a primary and a urologist who I really don't want to see again, and my active oncologist about whom I've had some pretty negative comments from the group in terms of his competence. I just saw him again on December the 13th, and my PSA, my only treatment is a Firmagon, and my initial treatment took my PSA down from around 85 down to 0.73, and my last PSA was 0.03. So it's really dropping, and he seems, and it seems to me too, that it's pretty effective in this situation. However, my feedback from the group, from Rick, is that I'm not getting standard of care, and I did bring up to him about adding a second line of I guess ADT or whatever, the standard kind of stuff, or Firmagon with darolutamide or something. And he seemed to say, well, no, we don't have to do that. Let's just keep doing the Firmagon and just kind of wait and see what happens. Meaning that he seems to want to wait around until my PSA starts rising again. And my reading and looking at the guidelines on that section 5 in the guidelines about the standard of care and how they make it pretty clear that the best way to do this is with 2 lines of treatment. So I kind of let that go. I didn't argue with him or anything like that.
Fred,
okay.
Thomas, let us jump in because we don't have a lot of time. We've got a couple of other guys that really want to get to. Look, the standard of care is the standard of care for a reason. It's because they've done clinical trials and they can show that whatever the endpoint was they chose, it is longer with 2 drugs than with 1. I don't know. I can't remember whether it was overall survival, whether it was radiation-free progression, but whatever it was. Now, these urologists don't necessarily stay up with advanced cancer. They stay up with Firmagon and Lupron because every 3 months or 2 months or 6 weeks they give you a shot. They ring the till and they love it. And they don't want to lose you to somebody who's not going to do that. And there are plenty of webinars continuing medical education webinars to teach these urologists what to do. I attend quite a few of them. So do the other guys. Now, we can't tell you what to do. We can only tell you what we would do. And you need to get yourself a genitourinary medical oncologist, because God forbid a year from now you come in and something has happened and the disease has spread. We're going to say, but you chose to do what wasn't standard of care. You wanted to stay with your urologist. Now we're going to have to deal with it the best we can.
No, listen. You said the same thing in the last meeting. I want to make it clear, I'm not staying with that urologist. I think I said I don't want to go back to that urologist. I have an oncologist who is not applying the standard of care at a oncology outfit here in Vancouver, Washington. On January 3rd, I have an appointment with Katerina. I can't remember her name. The Russian Sokolova. Katerina.
Oh, Sokolova, great.
Yes, I have an appointment with her at OHSU.
Okay.
And really, my question tonight is, and I said I'm listening to the talk tonight and how people are navigating between these doctors. I'm wondering, is it okay? I mean, I can do whatever I want to do. I get that idea. I know that I've got this disease, and I don't really have to take a lot of BS from anybody. I mean, I want to be courteous. Yes, but if I want something, I'm going to ask for it. But can I keep both of these people? Can I have two oncologists? Do I have to drop the other oncologist? And I don't mean have to. I mean just okay, get rid of that oncologist. If Sokolova is good, and
so again, can we answer you?
Go right ahead.
You need you need somebody like Sokolova to guide your prostate cancer treatment. Should
Right.
you keep your urologist? Yes, because if you have other issues that are urological issues, you'll need a urologist. If you have issues, around incontinence or kidney stones or something else, you might need a urologist. So you keep them on for that function, but in terms of getting your prostate cancer care, you go to Sokolova.
Yeah, I mean that's what I'm planning to do. That's why I've got that appointment on the 3rd, and I'm hoping that I mean that's what my search is for, this genitourinary prostate oncologist. To start getting the treatment right. So I mean I just kind of want to walk in there and say, okay, what are you going to do now, and listen to what she has to say, and
Right.
see if I get the standard of care.
And let's see what she says. Larry Fish, don't go away. Don't go away. I want to talk to you before we're done tonight. So I keep on watching. Anybody else have any advice for Tom Matika on how he should navigate his doctors here?
Call me
Len.
Thomas.
Anybody? Len.
He's doing the right thing, right? He's seeing an oncologist. Is there an echo on my voice?
Very slight, but keep
Yes, there
talking.
was.
Well, he's seeing an oncologist that you folks approve of, and he's got the appointment January 3rd. What navigation does he need beyond that?
Right.
That sounds to me like I've done the right thing and I'm on the right path. I just don't have as long a trail of doctor visits as a lot of people on the seminar do. I mean, because I'm just kind of starting this. I just want to make sure I'm taking the right steps. It's why I'm listening and why I'm trying to learn. Tonight, I mean, I'm sitting here thinking these guys are doing what I think I have to do, and so I mean, I'm the seminar is very valuable in that light. But I do want to make it clear, I'm not stuck on a urologist. I'm gonna get rid of that guy. I'm going to get another urologist too.
Well, I think it was just that when you said to me you went back to him on December 13th, I was kind of wondering why.
Now, I went to
So,
the oncologist on the 13th.
oh, you went to the, okay, got it.
Yes. Yeah, I'm under
Okay,
treatment,
sorry.
Firmagon treatment.
Okay, okay.
That's enough. That's enough.
Great.
Okay, can we move?
I just want to say a quick thing that to Mr. Fish, who I did interrupt to go to because something was important, and then he left, and I didn't mean to offend him. So I just want to make sure I'm still in his good books.
It's not so easy to stay in my good books. It's just asking me. I need
I know.
I need something concrete. No, I had something to say that was relevant at one moment, and by the time it went on, it was no longer relevant, and I had other things to do.
Okay. Can you remember what the relevant thing was?
Oh, well, the guy was talking about his problems with constipation, and he was describing using psyllium, and I've been through using psyllium for constipation, but I found that if you add 3 or 4 like large prunes, that problem is resolved for me. And I had that problem for many years, and I no longer have that problem. I wanted to tell him, think about adding that, because I understood the whole path that he was taking. But by that time, things had moved on, so I didn't have a chance to talk about it.
All right, you heard it here first, guys. Prunes for constipation. Never heard that before.
Oh, but I mean, when you add it to psyllium, which is a non-digestible fiber.
Yeah, but
listen to your mothers, everybody.
Right. My mother
the
swore
thing
by
is,
prunes every morning, sunshine prunes.
I do it at night, and that combination resolved my chronic constipation issue.
well, that's good, but somebody suggested that in the chat window here that psyllium could be helpful to Peter Kafka, but that was for that was to stop rather than to start. You're muted, Peter.
Psyllium adds, bulk fiber that's non-digestible. So that can help with diarrhea. It can also help with constipation.
You're muted, Peter.
Yes, that's what psyllium is for diarrhea. It's not for constipation. And I've been eating prunes. I've been eating a couple of prunes a day for years. I buy them in the health food store, and it's great for regularity. Yeah.
Yeah. Well, I'm doing both, and psyllium helps with both. It increases the bulk, which increases the peristalsis.
Yes.
And then prunes also encourage. So that combination resolved my issues with constipation, and I know that it resolves people's issues with diarrhea also. But I wasn't talking about diarrhea.
Good.
Okay.
Peter, I meant to comment when you were speaking earlier on that have they given any thought to the fact that maybe the immunotherapy caused IBS, not IBD, IBS?
Could well be. It's on my radar. I mean, yeah, it's one of the known side effects, not IBS, but necessarily, but constipation and diarrhea particularly is a big side effect of immunotherapy. But again, I've been off immunotherapy now for 5 months. But whether it caused permanent damage, I don't know.
Harry
I wonder if
Harry
it's worth calling Merck up.
Well, they'll probably just refer you to your doctor.
Right.
Harry Spieler, you have something to contribute on this discussion I see in the chat window.
I've had diverticulitis issues, constipation, and my gastroenterologist, at least he informed me that psyllium can make constipation worse, but it's helpful for diarrhea. So that's just my understanding. I'm sure things work differently for everybody, but that's what I've been told, though, and that's how it's worked for me.
Yeah,
That's my
it's
2
tricky.
cents.
Psyllium is tricky. You have to really know how to use it. You can look, you can see a lot of warnings in YouTube videos and things. You need to have a lot of water with it in order for it to work or to help constipation. A lot of water. That combination of a little, anyway, you could look it up, psyllium. But it's very helpful for constipation and for diarrhea. It's the same as taking Metamucil. I mean, it's pure non-digestible fiber.
Isn't that Citracel? What isn't Citracel? Oh, that's
Yes.
methyl cellulose, I think.
Yeah.
Well, anyway, Gary Peters, you are up.
Len, given the time, I'll pass till next week. I will just add, coincidentally to Jimmy and Ravi, I had my radical prostatectomy at Hopkins with a Hopkins urologist who did not tell me about a couple of possible side effects that happened. And after they happened, he basically washed his hands of me too. So it may be maybe something that is more pervasive.
Ravi, did you want to comment on that?
Yeah, who was the surgeon, Gary?
The name was Han.
Han, yeah, I see. Okay. Thank you.
Okay, and Gary, you sure you don't want to go now?
You're the last one, Gary, so you can do
You're
it.
the last one.
Okay, I'll be quick. So I have finished actually a little more than 2 years of abiraterone and 3 years of Eligard to get my PSA undetectable. And so in accordance with the protocol in the Stampede trial, I'm going to stop treatment now and see what happens. Unfortunately, I think I had mentioned that when I got off the abiraterone and weaned off the prednisone, my adrenal glands had never resumed producing cortisol on their own. And that still has not changed. I'm having to rely on a different steroid each day to produce some cortisol, and now the doctors are telling me that most people recover this, but some people don't. So I was just wondering if Jack and Jeff had any experience with this, or if anyone else in the group has had experience with this.
Anybody want to talk about lazy adrenals and supplementing them and etc.? One of the doctors in the house, maybe?
Jack is speaking, but I can't hear him.
In my experience, most people recover. It's very rare that you run out of cortisone. But it could be a sluggish, slow process. I can't say, how long that'll be. I'm not an endocrinologist.
Okay,
Sorry.
that's encouraging.
So what are they giving you, Gary? You're still taking the prednisone or something else?
Hydrocortisone.
Oh.
I'm not clear on what the reason for the change is, but I was happy to get rid of the prednisone for any reason.
Are you doing better on the hydrocortisone than you were on the prednisone?
I think so. I had a lot of side effects from the prednisone. I don't feel as many side effects with the hydrocortisone. I'm just, battling this darn fatigue. Cortisol is the hormone that wakes you up in the morning. And it's um, it's a big change not to have it.
So I know Alexa talked to you at some length because she has some experience from her thyroid cancer with these issues around the adrenals, and she's very knowledgeable. She sits on that CDC committee for rare diseases, like some of you guys sit for prostate cancer. So she's pretty smart in this area and other areas. I mean, you certainly feel free to use her as a resource. Dr. John, do you have anything to contribute on this one?
I think that we had a guy, I don't know, a year or two ago who actually had Addison's disease. I think it was a tremendous coincidence. Whether you can have Addison's disease, well, I don't even know if you'd call it that. I guess you'd just call it hypoadrenalism as a result of abiraterone plus prednisone therapy for 2 years. I don't know. But anybody that can't get off their prednisone after a reasonable amount of months has to make sure that they don't have Addison's disease. Your endocrinologist, if you got one, will work you up for that. I don't know if your primary care doc will do it, and it can be from the adrenals or from the pituitary or hypothalamus. They know how to work up all that stuff. And it's a rare disease, but when people get treated for it, they sure feel a lot better.
You're saying Hodgkin's, John?
Addison.
Oh, Addison's. I think I have the reverse. It's the reverse.
The reverse is like Cushing's disease, where you have too much steroids.
Oh, okay. Then it would be Addison's.
Like Jack says, the endocrinologists know all about that whole axis and how to test the various parts of it.
Right.
Now, the other thing, and I don't know if it's relevant, but our board president recently got diagnosed with Graves' disease, which was a lack of having some of these hormones too.
Yeah, that's another one of the hypothalamic pituitary endocrine axes. That one ends up with the thyroid instead of the adrenal, but it's a very similar situation.
And they put him on a drug, and he's doing great. I spoke to him just yesterday, and he's feeling so much better. It's like night and day. So, that was a drug called methimazole. I don't know quite how to pronounce it, but what I'm thinking, Gary, is that the suggestions that are coming out of here are solid in that maybe you should be seeing an endocrinologist because maybe there's something else going on, or something that this long-term supplementation did to your endocrine system. Have you?
I am seeing an endocrinologist. She's the one who put me on the hydrocortisone.
Okay.
Oh, okay. Then I don't think we have to worry about mysterious unknown things going on because they know what they're doing.
Yeah,
We
I
used to
think
have
she.
a GYN endocrinologist on this call a few years ago. It was very helpful when strange things happened. Wonder whatever happened to him.
Trying to remember who that was.
I can't
I'm
quite.
not.
It was a doctor, and he was a specialist, a subspecialist in
I
endocrinological
think that was
OBGYN.
Mark Perlow, no?
Oh,
Was that?
Mark Perlow. Yes. Oh, he's around.
Yeah.
He just doesn't come to this group anymore. He comes into the low intermediate all the time.
Oh, good. Okay.
Gary, how do you take the hydrocortisone? Is it you dissolve tablets in
Uh,
water and drink them?
Oral tablets. Yeah, just with like any normal tablet with a glass of water.
Yeah. Okay.
Why do you ask, Len?
Well, I'm curious as to why they are giving him hydrocortisone instead of what they do with when you're on Abby, which is to give them prednisone to supplement the loss of cortisol.
Well, but he was having problems with prednisone.
Okay, what were the problems?
Well, it had caused a lot of deterioration of my bones.
Ah,
It was making me super hungry. I think it was contributing to weight gain.
okay.
But I don't know. I don't know why hydrocortisone is a better drug for this problem. I don't know the answer to that. It's a good question.
Excuse me, Gary, you had a case of the munchies? An extreme case of the munchies.
Yes.
Oh, wow. That's bad.
Prednisone will do that. Prednisone will do that to you.
Yeah.
How long did it take you to get off the prednisone, Gary?
You know, I was taking a long time. I like tried to do it over a couple of months, and I was fine until I got down to 2 milligrams, and at 2 milligrams I felt like I hit a wall, and I said something's wrong. So I went to this endocrinologist, and I think they did actually test my pituitary too, but this popped right out that I was not getting any cortisol.
You might be struggling still with the prednisone withdrawal. That's what happened to me. It took me, 3 months or so. It was terrible.
And
Dropped my testosterone, did all kinds of weird stuff to me. I felt really bad coming off of it.
well, it's been now 3 months. It's been 4 months.
Yeah, it can take a while. You were on it for quite a while. It can take quite a while to get it out of your system because it really messes with your adrenals.
Yeah. Well, I hope you're right. I hope it's just a matter of time.
Are you going to try to taper off the hydrocortisone, or is this like a standing order right now?
So standing order right now until I see her again I get new blood tests and see her again in early February.
I mean, I think the only thing I'd say at this point is if you don't see much of a difference on the hydrocortisone, maybe move it forward, because that's still another 6 or 7 weeks away. And if it isn't making a difference, the squeaky wheel gets the grease, Gary Peters.
But it is helping. He's better. It sounds like Gary's better off on this than on prednisone, and he's stable
Right.
for the present time. So I think that the endocrinologist has made things better.
Okay. I stand corrected.
Well, I mean, he's still got the fatigue, I do
Gary,
too, and
are
it's
you
been a
are
year.
you on Xgeva or Prolia or anything?
Prolia.
Finished.
I'm still on Prolia, but no longer abiraterone or Eligard.
Okay, guys.
Thank you, guys.
Any last comments or questions for Gary or anything or anybody?
Have a great
Thanks,
holiday
Len.
weekend.
The last thing is that we will be meeting the day after Christmas. So I think Dr. John, provided he's here. If not, I'll fill in for him.
No, that'll be me. I'll be okay unless this family emergency thing
Right,
happens.
right.
Yeah,
That's what I was thinking.
yeah.
But
Thank
we
you.
we do have a meeting next week. All
All
right,
right, guys, I
gents.
apologize for my computer issues. Thank you, Rick, for taking over. And we'll see John next week, day after Christmas.
The day after Christmas. Good night, everybody.
Hey,
Good night.
everybody.
Bye, guys.
Good night.
Happy holidays.
Happy holidays.